Okay, this is lecture number 2 on oxygenation and bag valve masking. I think this is a pretty important lecture. I think it'll have a couple tips in it that'll change how most providers use a bag valve mask and oxygenate and pre-oxygenate a patient. So of course the game is oxygenation. We're always just looking at the pulse oximetry and understand, and most of us know that at 90% it sort of drops down pretty quickly. But we want to do as much as we can to click it up here above 100 and get as much PO2 as possible. So once we can get it way over 100, maybe up to 600, the more we do that right before intubation, the better off we are, the more apnea time we have, and in theory, the better off the patients come. Remember, oxygen's the name of the game no matter where you are in the airway algorithm. So this is probably the most important graph in airway management for sure. So we'll talk about different ways to maintain the oxygenation. Of course, how to open the airway with suction and airway maneuvers and adjuncts, how to maximize their patient positioning, increase their FiO2, their inspired O2, and a little bit on positive pressure ventilation. So step 1, make sure the suction's on and checked. There are lots of hoses in here that can get disconnected, and every hospital seems to be a little bit different ways in which you can screw it up. So make sure you understand the ins and outs of making sure that works. It should normally be placed under the patient's right shoulder whenever you're doing sort of airway management. And never cram that suction in farther than you can see. And remember, there's always the trick. If they're really hosing out their mouth, you can use 2 suctions at the same time. We are teaching this Mohn's mnemonic from Wandswall's course to predict difficult bag valve mask. It means M for difficulty with a mask seal, so the beard is a classic example of that. But there can be external trauma, all sorts of reasons to have a difficult mask seal. Obesity and obstruction makes it more difficult to provide bag valve masking. Age greater than 55, no teeth. Remember, if you're trying to get a mask seal on a patient with dentures, you're usually better off with the dentures in. And stiff lungs is a classic time in which it's difficult to provide a bag valve mask, or difficulty moving their head with a C-spine. So it's MOANS, and that's something to remember. It's also on the back of our airway checklist to remind us. Of course, this is our algorithm on airway management. And, the classic thing is laryngoscopy first and try it again, maybe some different type of laryngoscopy, then put a LMA or bag valve mask in, and finally a crike. But in reality, the most important tool is your bag valve mask, that you can usually go back to that. It's not just used here in between attempts at laryngoscopy. There are many instances where your plan A is, let's see if we can bag this person up with our maximal use of our bag valve mask. It can certainly be your plan B, a failed attempt at laryngoscopy. You can try to bag them and re-oxygenate them that way. And it can be a plan C, of course, as well. So it's probably the most important tool in the airway kit. I know everyone says that, and everyone agrees it doesn't get the respect it deserves. But it can deliver the oxygen, it can actually help you maintain an open airway, and it can deliver ventilations. Just as an aside, the SAT probe, of course, is an important part. It helps us, track our oxygenation, and so make sure you get a trace and place the probe on the opposite, not on the same finger as the blood pressure cuff-off is on. Again, there's a great Ruben Slayer video here. It's 11 minutes long on how to ventilate. Probably it's better than this one. Listen to that in conjunction of this, and I think you'll have some good goes. Here's how to use your mask. Remember, you're always pulling the patient's jaw up into the mask. You're never pushing the mask down on the patient's face. You can even lift the whole patient's head off the bed. Appropriate masking position, just to cut ahead, is the same as appropriate intubation position. So the more you can position them, the better. Many anesthetics providers here are trained and actually succeed pretty well on doing one-handed mask seal on even difficult masking. But unless you're doing it every day, it's very difficult for most providers to provide a good, solid mask seal with a single hand. This has been researched. It's been shown on models. But basically, there's a 2-hand mask seal, either with both thumbs down or the double EC. Both of these guys are pulling the jaw up into the mask and getting most of their seal that way. Neither of these matter, whichever is more comfortable to you. They both provide the same effectiveness, but they are definitely superior to this in any but the most sort of expert bag master. If this patient requires masking in the emergency department, they almost certainly need 2-person masking. So that's certainly, if you can't get any SATs, there should be 2 people up on that head trying to bag those SATs up. If they have low SATs, same deal, 2 people. If they have either predicted or actual difficult bag valve mask, they should have two people, 2 hands making the seal, 2 hands squeezing the bag. And then if the patient is desatted previously or in between laryngoscopy attempts. So we're really trying to discourage a single provider up there at the top trying to maintain a mask seal on a difficult patient. So I'm not going to go over all the things, but airway adjuncts can very much help you have a effective bag valve masking. You can use a nasal pharyngeal, you can use an oral pharyngeal, you can use them both at the same time. You can even use 2 nasal pharyngeals if you're having a difficult time. Of course, together with 2 hands of mask seal, they work sort of in conjunction. So we'll talk a little bit about how to deliver oxygen through either a non-rebreather or a bag valve mask. The non-rebreather is the classic thing. It actually provides 95% FiO2 if there's a reservoir. It's a good nice seal around the corner. If you place a nasal cannula under there, it's likely to provide even higher, maybe up to 100% FiO2. If the patient isn't breathing at all, it's probably not quite good enough. However, if the patient is breathing, normally a regular bag valve mask only provides 70% FiO2. You can bring that up if you're using actual positive pressure, if you have a nice tight seal with the oxygen on, a reservoir bag, and you should probably put a PEEP valve and a nasal cannula even under that. We'll review that a few more times. But basically, if a patient's sick enough to be considering intubating them or sick enough to really be needing a bag valve mask, they probably almost certainly need a nasal cannula under there, also turned up providing oxygen. Here's probably the essential table from the most important airway paper published maybe in the last 5 or 10 years. It's the Weingart-Levitan paper on pre-oxygenation and prevention of desaturation during airway management. And it divides our patients into low risk, high risk, or hypoxemic patients, and then divides the time period of their airway course as the pre-oxygenation period, after you give the muscle relaxants, and during the apneic period of their tracheal intubation. So we'll talk very briefly about the low risk patients, which they exist, but they're not very common in the ED. You can probably just put a non-rebreather mask on them with a nasal cannula that you turn on after you give the muscle relaxants, and then leave the nasal apneic oxygenation on during the intubation phase. That's fine. For many of our patients, though, they're high risk. They're patients who are having trouble getting our pulse oximetry over 95%. For those patients, you could definitely at least want a non-rebreather mask for 3 minutes before you give the drugs. But you can give CPAP or a bag valve mask with a PEEP valve on is probably better. And then, of course, you'll leave that PEEP valve and the bag valve mask and the nasal cannula on with a nice tight seal during the whole 3-minute pre-oxygenation period, during the onset of muscle relaxation, and during the apneic period. If a patient's hypoxemic, this becomes a little much more difficult. You can't get the patient's SATs over 90% before you attempt to intubate this patient. And this is something, although it's actually somewhat routine for us in the emergency department, there are very few other providers that sort of have much experience with this. So it's something we need to be the masters of. So you'll need a CPAP. You'll definitely need a nice tight seal with a PEEP device. You'll definitely want that nasal oxygen on underneath it, and try to do your best. There's some other more advanced techniques you can use, but this at the very least is what you need. And we'll go over this. So just to review again, sort of the sentient points, both a non-hypoxic patient and a high-risk patient and a hypoxic patient, they both need a nasal cannula. If they're non-hypoxic, you can probably just get away with putting a non-rebreather mask on top of that. But with a hypoxic or a high-risk patient, you'll want a bag valve mask appropriately put together with 2-handed seal, with a PEEPS valve, with an end-tidal CO2 attached on top of the nasal cannula. There's a whole delayed sequence intubation or a rapid sequence airway or using non-invasive ventilation beforehand. We won't talk about that during this course. So oxygenation, here's some tips, right? Again, I've probably beaten this to death or not, but the nasal cannula under the bag valve mask can help. A PEEP valve can help. And then another thing that's probably a practice change for many of us is the end-tidal CO2 detector should be placed on the bag, in between the bag and the mask beforehand. This does 2 things. One, it warms up the sensor, which since we have a side stream sensor, it takes a while to warm up. Additionally, it shows everybody how fast you're bagging. And then remember, hypoxia is not treated with hyperventilation. Hypoxia is treated with PEEP and increasing the FiO2, whether you're on a vent, whether you're using a bag valve mask, or whether you're using any sort of non-invasive ventilation. Its rate does not treat hypoxia, and basically it's never indicated to hyperventilate a patient through a bag valve mask. Patient positioning, so these are all pictures from intubation, but basically the positioning a patient properly for intubation will also have them at maximal effectiveness for bag valve masking. So that means ear to sternal notch level, face will be parallel to the sternum, and their head up. So ear to sternal notch level, we'll talk about this again during laryngoscopy, but you can call it the sniffing, you can call it the flexing the neck, you can call it elevating the head. The point is the ear has to be at the same level as the sternum notch. If they're really fat, they might need a ramp. That, for one, it opens their tracheal axis so you can see, but it also makes it the widest diameter possible for ventilation, and that's really key. So position them for bag valve masking. You can ramp them if they're quite large. You do want their face parallel to the ceiling. And then even if they're a trauma or something, not only does it make their ventilation easier from the airway side of things, it also probably makes the ventilation easier from their visceral organs or off their diaphragm. You might need a stool, and you can also just raise the whole head of the bed. Bed height, you do want it to be appropriate for bagging, right? It should be at about your xiphoid. That means you might need a stool. And then for manual inline stabilization, this is just something we need to talk about somewhere in this, and actually probably bag valve masking moves their neck just as much as intubation. So you need to have a system. That means usually the front of the collar has to be off, otherwise you can't open the mouth. And somebody's hands need to be there mostly to remind whoever's manipulating the airway not to manipulate the airway. So it does help make it so the head doesn't move around as well. But basically that person's job, as much as anything, is to tell people, hey, you're kind of cranking on this person's face a little too much. And you can be either at the head of the bed looking down towards the feet, like in this guy, or at the patient's shoulder facing the airway operators looking up towards the head. And of course, if you're ever having trouble with intubation or with bag valve mask, and you're always welcome to release your manual inline stabilization in order to oxygenate the patient. So again, we're going to just remind everyone, your airway algorithm can very much center around your bag valve masking. You can try to bag that hypoxic patient up. You can try to bag that patient up after you've had an intubation attempt. You can try to bag that patient up after you've had a couple intubation attempts. You do want to use all the tricks. You want to have a non-needle cannula. You want to have a PEEP valve. You want to have the end tidal CO2 on it. And you want to use your airway adjuncts appropriately. Here's just something to leave you looking at the checklist. We're not going to talk about it here. But remember, it's not a manual, and it should be used as a call response thing, as a final check right before you give the drugs. And, usually while someone's bagging, someone else can be sort of planning for the next step and thinking about what needs to be done next for the patient. So great. So here's some great stuff. There's the Weingart paper, of course. There's the Rubenslayer's screencast. Then the Own the Oxygen is awesome by Life in the Fast Lane and Chris Lixon. And we have Dr. Levitan has some good stuff, and Kim Lewinberg from KI Docs has some other great stuff. Check it out below. I'd love to hear your comments, and I hope you have a good time. Next, we're going to go on to supraglottic airways.